is that we are joined from Halifax by a great educator and a great friend, Dr. Nader Hamdan. For those of you who haven't met Dr. Hamdan is a certified periodontist of the Royal College of Dental Surgeons of Canada. He is the head of the perio department at Dalhousie University. Just to name only few things about him, and he has been very supportive of our study club. Some of you have met him in person. He had, and as well, he had influenced quite a bit of people and helped quite a bit of people. And one of them as well is joining with us, a good friend, a good colleague. His name is Dr. Ibrahim Shoaib. He's a third-year resident in NYU University in the Department of Periodontology. So, Dr. Salam, you have quite a bit of, challenges today. Hope you're very well prepared. We're not going to keep talking. I'm going to give it to you. And at the end, maybe Dr. Nader can say a couple of things and, add and comment on your presentation. You can take the lead.
Okay. Good evening, everyone. First, Ramadan Mubarak and Happy New Year to all those who are celebrating. So today we're going to carry on. The last presentation we talked about the new classification scheme for periodontal and peri-implant diseases and conditions. We spoke about what was new in this workshop. Today we're only going to focus. So sorry, this is my screen. All right. Yeah. So this is the outline of the workshop. Today, we're only going to focus on periodontitis in particular, the staging, extent, and grading, how to determine these to come up with the diagnosis for the patient. First, we're just going to recap what we already talked about in the last presentation. I'm going to go through it quickly. So with staging is largely dependent upon two things. We said the severity of the disease at the presentation and the complexity of the disease management. There are several variables that determine the staging. We have 4 stages, 1, 2, 3, 4. It's very important to know that once we go into a stage that the patient cannot go back to, like if the patient is stage 3, he can't go back to stage 2. If he's stage 4, he can't go back to stage 3. So these variables are clinical attachment loss, the amount of percentage of bone loss, cropping depth, present and extent of angular bony defects, or in other words, the bone loss pattern, furcation involvement, tooth mobility, and tooth loss due to periodontitis. This table here explains more about these stages. So the first thing we look at when we want to determine the stage for the patient is the clinical attachment loss whenever the CEJ is detectable. So whenever we have 1 to 2 millimeter clinical attachment loss, that means the patient is still in the stage 1. When we have 3 to 4 millimeters, that means the patient is in stage 2. Stage 3 and 4, we have 5 millimeter or more of clinical attachment loss. So an easy way to memorize it, 1, 2, 3, 4, and then we have 5. What we do if we can't detect the CEJ, it's hard for us. So we resort to the radiographic bone loss. In the first 2 stages, the bone loss is still in the coronal third. Of course, in stage 1, it's less severe, so we have less than 15%. In the stage 2, we have 15 to 33%. Stage 3 or 4, the bone loss is extending to the middle third of the root and beyond. Tooth loss due to periodontitis in the first 2 stages, we don't have any bone loss. In stage 3, we have 4 or less. In stage 4, we have 5 or more. This is regarding the severity. Regarding the complexity of the treatment, we look at 2 things. We have the probing depth and the bone loss pattern. Probing depth in stage 1 is 4 millimeter or less. Stage 2 is 5 millimeter or less. Stage 3 and 4, it's 6 millimeter or more. What about the bone loss pattern? First 2 stages is still horizontal. In stage 3 and 4, we start to have vertical bone loss of 3 millimeter or more. What else do we have in stage 3? We start having furcation involvement, class 2 or 4, and moderate ridge defect. So for stage 4, in addition to everything we had in stage 3, we add to it the need of complex rehabilitation. What that means that the patient, due to periodontitis, start to have some occlusal trauma, bite collapse, drifting and flaring of teeth. The severe ridge defect due to the teeth that were lost due to periodontitis, and he has mostly 20 remaining teeth, 10 opposing pairs. What about the extent and distribution? This is very easy to determine. So we have the rule of the 30% of the teeth present in the mouth. So whenever we have less than 30% of the teeth involved in the periodontitis, this is localized. When we have 30% or more of the teeth had periodontitis, this is generalized. Moving on to the grading. So the grading provides supplemental information about the biological feature of the disease. What does that mean? It gives us an idea about how this disease is progressing. So first, we have the history-based analysis and of the rate of the progression. So we look at the past or prior records of the patient to determine how much bone were lost in the past 5 years. We assess the risk for further progression. So we can predict what's going to happen in the future somehow, and anticipated the outcome of the treatment we're carrying. Also, we assess the risk that the disease or its treatment may negatively affect the general health of the patient. This table also explain more about the grading. How do we determine? So we have kind of a rule that the clinician should initially assume grade B. So each periodontitis patient comes in the office, we assume grade B, unless we have other factors that indicate no, that he's grade A or grade C. So what does grade, let's start first. How do we determine which grade, or how do we determine if he's grade B or different or other grade? So we have direct evidence of progression. So we have radiographic bone loss or clinical attachment loss over the past 5 years. So as I said, we look at the prior record of the patient. In case we notice that there was no bone loss happening over the past 5 years, that means the patient is in a slow rate. So he's still in grade A. If we notice that there is bone loss, but it's still like mild 2 or less millimeters, so sorry, less than 2 millimeters, this is moderate rate, so this is grade B. In case 2 millimeters or more, then this is the rapid rate, so this is grade C. So we all know that most of the time, the patient, when he comes in the office, he doesn't have prior records, he doesn't usually carry all his X-ray. We're lucky if he does. So what do we do in this case? We resort to the indirect evidence of progression. What does that mean? So we divide the percentage of bone loss over the age. So if the patient has the bone, like the bone level is only at the middle third of the root, the middle, like 50% bone loss, and he's 50 years of age, so we divide 50 over 50, this is 1. So what does that mean? So that means that the patient is in grade B. So if the number came to 0.25 or less, this is grade A. 0.25 to 1 is moderate, grade B. More than 1, this is grade C. Also, we look at the case phenotype. So we look at how much deposit or calculus the patient has, and is it proportionate to the destruction we're observing? If it is proportionate, that means it's a moderate rate. This is grade B. Sometimes we have patients that have a very heavy calculus that comes in the office, and after we do the cleaning, we anticipate that it's going to have maybe a more severe condition. We notice that it's still in the mild or still incipient. So that means it's not proportionate. You still have low levels of destruction. This is a very slow rate, and this is a good thing. This is grade A. When the destruction exceed our expectation, so he doesn't have much biofilm or black, but he still have severe destruction, this is a very rapid rate, grade C. What does that suggest? It should suggest that the patient had been through periods of rapid progression and or early onset of the disease. We have also grade modifiers. So this is risk factors. We have 2 things we look at: whether the patient is smoker and whether the patient have diabetes. If the patient is non-smoker, he doesn't have diabetes, it's a slow rate, so it doesn't affect the periodontitis, he's still in the grade A. If he smokes less than 10 cigarettes a day, he's grade B. If he smokes 10 or more, then this is the rapid rate, this is grade C. Regarding periodontitis, we look at the HbA1c to see how controlled the diabetes is. If the number comes to less than 7%, it's like somehow controlled, so this is a grade B. If it's 7% or more, then that means the rapid rate patients have grade C. Now let's look at some cases or some example for what we talked about. Let's look at this case. So this patient Looks like he has, when we look at the clinical attachment loss of the greatest loss area, it's less than 2 millimeters whenever the CEJ is detectable. The maximum interdental probing depth was 4 millimeter or less. Radiographic bone loss is still in the coronal third of the root and less than 15%. And there are no tooth loss that happened due to periodontitis. So this is a very incipient case of periodontitis. This is still in the early stages, so this is stage 1. Let's look at this case here. So we notice that it's becoming more severe, especially if we want to look at these areas. So the interdental clinical attachment loss here, so it's 3 to 4. As we remember, we said the stage 1 is 1 to 2, stage 2 is 3 to 4. The maximum interdental probing depth is 5 millimeter or less. Radiographic bone loss is still in the coronal third. As we said, stage 1 and 2 still in the coronal third, but here it's 15 to 33% of the root. Of course, no tooth loss happening due to periodontitis, so our patient is still in stage 2. So this case here is the interdental clinical attachment loss at the greatest loss. Here we see like it's detectable in some places. So it's 5 millimeters or more. And there are tooth loss that happen due to periodontitis. So that means the patient is in stage 3. Let's look at the dental chart for this patient and the radiograph. So I'm just going to zoom in a little bit. So if we look at the periodontal chart, we notice that the pocket depth, we start having 6 millimeter or more, as we spoke earlier. That indicates that the patient is grade 3 or 4, depending on the other factors. Let's look at the X-ray here. So what we notice here, we notice tooth loss happened due to periodontitis, ridge defect. We notice vertical bone loss in this area, 3 millimeter or more. We also notice furcation involvement of class 2 or 3. Clinical example for stage 4. This is obviously very severe, so we can easily detect the CEJ here. At the greatest loss, we see that is 5 millimeter or more. The bone loss is extended to the middle third of the root or beyond. So let's look at the periodontal chart. Let's look, at this. Actually, the root is visible, the furcation is visible. So let's see the radiograph for this patient. Again, the periodontal chart indicates 6 millimeter, 7, we even have 8 and 9 in some places. Okay, the radiograph, what does it show? It shows that we have furcation involvement, vertical bone loss, ridge defect is very severe here. So what, in addition to everything we observed in the stage 3, we also have drifting of teeth or flaring. We notice that we have So we notice how we have occlusal trauma. So the patient here needs a complex rehabilitation because of the masticatory dysfunction that happened due to periodontitis. This case here, we have a 50-year-old woman. She's not smoker. So there was no evidence of tooth loss over the past 5 years. The heavy biofilm deposit with low level of destruction, which that means it's still in the slow rate. This all indicates that the patient is grade A. Even if we do the calculation of the percent of bone loss over the age of the patient is going to come to be less than 0.25. The patient is non-smoker and she doesn't have diabetes. This patient here is a 74-year-old. She's not a smoker as well. However, she's diabetic. Diabetic with the HbA1c of less than 7%. Here we notice that she had bone loss of less than 2 millimeter over the 5 years. There's destruction, but it's proportionate to the biofilm deposit, which indicates it's a grade B. If we do the calculation as well, so the percent of bone loss over the age is between 0.25 and 1. Our patient here is 53-year-old. He's past smoker. So same, the bone loss is less than 2 millimeter over the 5 years. Destruction is proportionate with biofilm deposit, and the percentage is between 0.25 to 1. This young lady here is a 28-year-old. She's heavy smoker. Let's look at the clinical picture here. So, or compared to the radiograph. Let me just zoom in a little bit so maybe you can see better. So we see severe destruction. When we look at the clinical photo, so we do see like deposit, but it's not proportionate to the amount of destruction here. She has very severe bone loss. It's more than 2 millimeters over the past 5 years. The percentage of the bone loss over her age is only 28, so it's more than 1. She's a smoker and she smokes more than 10 cigarettes a day. And the destruction is not proportionate to the biofilm. So there's evidence of periods of rapid progression or early onset of the disease. So we do expect here a poor response to therapy, and this patient is in grade C, a very rapid progression. So now after we established or determined which stage or the grade the patient has, how do we treat this patient? So let's say our patient is still in the stage 1 or 2. We said that the clinical attachment loss is 1 to 2 in the stage 1 and is 3 to 4 in the stage 2. The pocket depth is less than 4 in the stage 1, less than 5 in the stage 2, what does that mean? That means we're still in the non-surgical phase of the treatment. So we always start with the phase 1, which is the non-surgical treatment. Well, we know that once we hit the 6 millimeter or more pocket depth, we do start with the surgical. So here we stay in the non-surgical treatment. No post-treatment tooth loss is expected, indicating that the stage 1 and 2 has good prognosis going into maintenance. We do phase 1 therapy. I'm going to elaborate more on phase 1 in the next slide. This is a very critical aspect of periodontal treatment. So patients who do not have adequate plaque or biofilm control will continue to lose attachment regardless of what surgical procedures are performed. What is stage 1? What is phase 1 treatment? So it includes the patient education and oral hygiene instruction, complete removal of supragingival calculus, correction or replacement of poorly fitting restorations and other prosthetic devices, restoration or temporization of carious lesion, orthodontic tooth movement, treatment of food impaction areas, treatment of occlusal trauma, extraction of hopeless teeth. Possible use of antimicrobial agent, including necessary plaque or biofilm sampling and sensitivity testing. So we notice here it's not only periodontal, like it's not only scaling root planing. So the phase 1 includes more general or like more rehabilitation to the case. So we treat resto, we treat prosto, we treat perio. This all contribute to the patient overall periodontal health. After this phase, we move the patient to the periodic recall visit. So the interval between visits is initially set at 3 months. If you remember at the last presentation, we said that periodontitis patient is periodontitis patient for life. So not that we started phase 1, the patient can just go and heal and he no longer have periodontitis. Once he has it, he's still gonna have to come to the office every 3 months. So we can do the charting, we can check the progression, we can see the compliance of the patient with the oral hygiene instruction. So let's move to stage 3 and 4. The treatment here will require surgical and possibly regenerative treatments. Why? Because we have pocket depth of 6 millimeter or more. Possible regenerative treatments because the patient has vertical bone loss and furcation involvement. There's potential for tooth loss. The complexity of implant and restorative treatment is increased, of course, as we have bridge defect. The patient may require multi-specialty treatment. The overall case for stage 3 has fair prognosis going into maintenance, while stage 4 has questionable prognosis going into maintenance. So stage 3 and stage 4, the phase 1 therapy that we just talked about. After that, so we do have the patient come after 4 weeks. We do a reassessment in case we see that the patient is compliant with the oral hygiene instruction, which means that there's no bleeding, like we can say that the bleeding has improved a lot. The oral hygiene is good, like the black is less, the patient is taking care. We can move the patient to the surgical treatment for the deep pockets that are more than 6 millimeter. If the patient is still not compliant, we're still in phase 1 until he gets, because we can't just move to the surgical unless we have the patient working with us at home too. So the surgical treatment should only occur once the patient demonstrates professional biofilm control. What is the objective of the surgical treatment? So why do we do the surgical treatment? We have 2 objectives. The primary one is access for root instrumentation. So we have to get better visualization of the root. The anatomy, we do have like some teeth that have special anatomy that we can't just see blindly or work, even if we do see subgingival scaling. Secondary is the pocket reduction through either soft tissue resection, osseous resection, or periodontal regeneration, such as GBR or GTR. Of course, extraction of hopeless teeth. Now, applying the new classification of periodontitis to clinical cases. Let's look at some cases, diagnose which stage or grade the patient has, and then look at the treatment. So the first case I have here is we have a 28 healthy male patient. He's smoked 5 cigarettes a day, so still less than 10, which is the cutoff between the grade B and the grade C. He attended the clinic. He was referred from his ortho office. He's bearer of fixed orthodontic apparatus, and he's an oral breather. So looking at the oral hygiene, we see that it's poor. The patient has large accumulation of bacterial plaque, along with gingival inflammation, bleeding, and food impaction. The dental history, however, the patient doesn't have any teeth missing, doesn't have any caries or restoration, and he presents numerous malpositioned teeth, mostly located in the lower arch here. So step one in diagnosing the patient. First, we have to confirm whether our patient has periodontitis or not. So we do take some x-rays. Of course, bite-wing x-rays are the go-to to see the interdental, the interproximal bone levels. So we see here the marginal bone loss is detected in the bite-wing, and it's therefore suspected that he has periodontitis. There's a bone loss. Complete periodontal study is performed. So we do periodontal charting. After we do the periodontal charting, we see step 2, attachment loss is greater than 1 millimeter and more than 1 non-adjacent teeth. The probing depth, that means greater than 4 millimeter in the interproximal areas, with no local factors present. Then it's confirmed that our patient has periodontitis. Now, step 3 is then performed to determine which stage and grade our patient has. Before we go into the stage and grade, we establish the extent. We see that the attachment loss affects more than 30% of the teeth. What does that mean? We say that less than 30% is localized, more than 30% our patient has generalized periodontitis. Then the next step is determining the stage. So our patient, we must consider the severity to distinguish which stage our patient has. He presents detectable attachment loss of less than 5 millimeter, radiographic bone loss in the first third of the root, and type 1 furcation. This is not to be confused. We did say that the patient has furcation involvement in stage 3 and 4, but it's type 2 or 3. So he only has type 1. He has no missing teeth. The patient thus has stage 1 or 2 periodontitis. I'm not sure why it's showing in the here. Okay, so how to distinguish if it's stage 1 or 2? We focus on the percentage of bone loss, which in this case, we have less than 15%. On the attachment loss is 1 to 2 millimeter. That means that our patient has stage 1 periodontitis. Then we do, after establishing the stage, we don't have any prior records for the patient. We have to establish the grades. So we do resort to the formula we have of the bone loss percentage over the age of the patient. Our patient here, the bone loss was estimated as 8%. So if we see here, still early stage, so 8% of the root. And then the patient is 28, dividing 8 over 28, the answer comes to 0.28. This indicates grade A. However, if you remember, we said our patient smoked 5 cigarettes a day, so he's a smoker. So we do modify the grade depending on that. So our patient here is grade B. How do we treat this patient? So how do we treat a patient with generalized periodontitis, stage 1, grade B? After systemic phase of advice on, of course, quitting smoking, this is the first step, the basic anti-inflammatory phase is performed. What is the basic inflammatory phase? Consists of instruction in oral hygiene, scaling and root planning in 2 sessions, together with the adjunctive use of chlorhexidine twice daily for 2 weeks. In addition, the wisdom teeth were extracted for orthodontic reasons. So of course, after we say this non-surgical debridement, basically, after that, we put the patient into maintenance phase. So we doesn't leave the clinic for good. He just have to come back 3 months after, and we just have to keep an eye on this patient so we make sure there's no progression of the disease. Another case we have is a 45-year-old woman. She comes to the office. She was referred by her general dentist for a perio evaluation. Her chief complaint was bad breath, bleeding, inflammation over the last 4 years, despite having spent 3 years in periodontal treatment. In addition, the upper incisor have flared. The medical history of the patient, so she has chronic autoimmune thyroiditis without the need for treatment. So she has been an ex-smoker for 5 years. She no longer smokes. Her dental history indicates her interest in resolving her perio issue, as periodontal access surgery has been performed in the mandible 4 weeks earlier, and prophylaxis has been performed frequently over a long time. She also had orthodontic treatment done 9 years ago. In the extraoral examination, everything was within normal limit. Intraoral examination reveals here congenital diastema between the central incisor, which was treated years ago. Overbite, here we can see, of 6 millimeter with occlusal trauma and protrusive, so she has eccentric phimosis. The gingiva presents an evident an increase in size, so she has some gingival enlargement, changing color. Of course, we can see it's more red, not pinkish in color, reddened gums, inflammation, especially in sextant 2, so this area is the most affected, as well as loss of scalloping and texture that is compatible with gingival health. Step 1 in determining the patient. So we suspect periodontitis. The patient, she had the panoramic X-ray with her, and because of her situation with thyroiditis, it was decided to only perform not to perform complete periapical, just only 2 periapical X-rays for the most affected area, the anterior superior sextant. So the step 2, the probing depth. So the periodontal probing was recorded. The interproximal attachment loss doesn't involve only local factors, and the complete periodontogram is performed. Our patient is periodontitis case because the interproximal attachment loss was greater than 4 millimeter at various sites. So the other step, as we said, we now we want to see the extent of the treatment. A full clinical examination is also performed. The results show periodontal pockets of 6 millimeter or more in 70% of sites, a bleeding index of 100%, black index of 48%, and she also presents mobility of grade 1 in the upper incisors. To evaluate the extent, so we said it's in 70% of the sites, so this is clearly generalized periodontitis. Now, to establish the stage of the periodontitis, we do assess the severity. So we look at the clinical attachment loss, bone loss, and teeth loss because of periodontitis, the complexity, the probing depth, and the pocket depth. So with the patient here, we have generalized periodontitis stage 3. So looking back here, so we saw that the pockets are more than 6 millimeter. She also has a vertical defect at tooth 1-1, looking back here at the pan X-ray. So it does have here vertical bone loss. Finally, to obtain the grade, we have to evaluate the bone loss over the age. The patient presents a bone loss of 75%, and she's 45 years of age. Dividing 75 over 45, we have number greater than 1, so this is clearly grade B. So she's greater than 1 with no additional risk factor. She's not diabetic, she's not smoker. The case is then generalized periodontitis stage 3, grade B. Fortunately, we have information about the development of this case 5 years later. Periodontal stability is observed both in clinical images and in periodontal radiographic records, and there's even some clinical attachment gain as well as partial correction of the diastema. So how do we treat this patient? First, a stage 3 grade B, she has anti-inflammatory periodontal treatment is carried out, which is the instruction of oral hygiene, scaling root planning in 24 hours. After 4 weeks, we had the patient come back, full patient record were taken to evaluate the response. Later, advanced regenerative periodontal treatment was performed in sextant 2, especially at the tooth 1-1, when we said we had the vertical bone loss. To eliminate the, and we first eliminate the irritant, polishing the development furrow of the root surface of 1-1 mesiopalatin, and the application of enamel-derived proteins, Emdogain, as well as antibiotic. We give the patient metronidazole 500 milligrams 3 times a day for 7 days. So in conclusion, when we have a patient walking in our office, first, the step one is we confirm whether the patient has periodontitis with the clinical examination and the radiograph. Once we establish that the patient has periodontitis, we do the full mouth periodontal charting, and then we, according to the charting, we establish the extent, the stage, and the grade. So I made these two slides just to the gist of the staging and grading, so we can just have that to help out in the office in case we have a periodontal patient and we want to diagnose the patient. We have these steps, easy steps. So the first thing, we determine the clinical attachment loss. 1 to 2, this is stage 1. 3 to 4 millimeters, stage 2. 5 millimeter or more, stage 3 or 4. In case we don't have clinical attachment loss, it's unavailable, so we resort to the radiographic bone loss. 50%, this is stage 1. 50% to 33%, this is stage 2. Middle third of the root or beyond, this is stage 3 or 4. Any tooth loss, we modify the stage accordingly. So if we have no tooth loss, then the patient's stage remains the same. 4 or less, this is stage 3. 4 or more, 5 or more, this is stage 4. We check the complexity factors. So we have the probing depth and the bone loss pattern. If the probing depth is 4 or less, with horizontal bone loss, stage 1. Maximum probing depth 5 millimeter or less with horizontal bone loss, stage 2. Stage 3, the maximum is 6 or more with vertical bone loss and furcation involvement class 2 or 3. Stage 4, in addition to everything in stage 3, we need complex rehabilitation, we have bite collapse, drifting, flaring, and less than 20 teeth remaining. How to determine the grade? The clinician should initially, as we said, assume grade B disease and seek specific evidence to shift to grade A or C. Radiographic bone loss or clinical attachment loss over the past 5 years. So if you have no bone loss, it's a grade A. If you have less than 2, this is grade B. 2 or more, this is grade C. In case we have no direct evidence of progression, so we resort to the bone loss divided by the age, or the case phenotype, when we look at the destruction compared to the dental plaque or the calculus or the biofilm. We have some grade modifiers. So if our patient is smoker or diabetic, if he's non-smoker, he doesn't have diabetes, this is grade 1. If he smokes less than 10 cigarettes a day, this is grade B. If he smokes 10 or more, this is grade C. If he's diabetic with HbA1c 7%, this is grade B. If it's more 7 or more, then this is grade C. Okay, so that was our presentation for today. Thank you everyone for listening. Now we'll move on to the discussion, or if anyone has any questions.
Thank you very much, Dr. Salam. I mean, it was a very detailed presentation. I am for sure finally understood the new classification. I never thought that I will. You've actually simplified it very nicely. I don't know if Dr. Hamdan would like to add anything or comment anything on the lecture.
Sorry, I was on mute. I was just trying to unmute myself. Ramadan Mubarak, everybody. Thank you very much, Dr. Hassan, for your kind invitation. And thank you so much, Dr. Salam, for this very thorough and nice, simplified presentation of the classification system. I enjoyed it. And definitely it shows your full understanding and grasp of the classification system and its implementation. You have done a great job, and very little can be said or added to your presentation. Unfortunately, I did not attend your first part of the presentation. But if you allow me, I want to add a few little things, if that's okay.
Of course.
Yeah, thank you. You mentioned that we can go back in staging, which is 100% true.
No.
There is one exception, though.
Yeah, there's one exception with bifurcation involvement. Right?
Yes,
like,
if you have
yes.
a regeneration of bifurcation, or even if you have an angular defect that you regenerated, and you manage to reverse the bone loss on an angular defect, because we can regenerate successfully any defects deeper than 3 millimeters and less than 25 degrees in angulation. So in this situation, if you have regeneration and you manage to treat a furcation 2 defect and make it furcation 1, that will change the
This-
staging. So this is the only exception.
Yes. Yes. Yeah. I'm aware of that. Sorry, but I didn't mention it.
Yeah, I'm sure
Yeah.
you are. I'm sure you are. I'm just reminding you, just for completion of the very nice presentation and the excellent work that you have done. To calculate the percentage of bone loss, I'm sure you know that, and because sometimes we really know it, we forgot to remind people that when you do the calculation, you take the worst site to do the math. So it's not the average bone loss. Like, you don't look at all the teeth and you say, well, here we lost 80%, here we lost 40%, so the average is 60%. Actually, you take the worst tooth, the worst site, and you make the calculation based on how much bone is lost on that worst tooth, based on the length of the root, and you divide by the patient's age. The first case, I wanted to check with you. There might have been some, the numbers are confusing always to all of us. You mentioned in the first case that the percentage of dividing bone loss by age came to 0.28, which is more than 0.25. And you said the patient would have been a grade A, except that he's a smoker, so that puts him as a grade B. But don't you agree that 0.28 will put the patient as a grade B anyway?
Yes. To be honest, I did notice that when I did the presentation, that he's like, I was a little bit confused. I did mention the source. It's from the European Federation of Periodontology.
I know.
This is where I got the clinical cases from. It was a little bit confusing for me because I thought that if it's 25%, then this is grade B. I'm not sure why they mentioned that. I just took it as like exactly how it is. But I agree with you.
That's true. Actually, there were a few mistakes that they have made, whether it's the European publications or the North American publications. Some of them made a few mistakes. Even the second case, when they did the ratio, it came greater than 1.
This is grade C.
Yes, that's a grade C. They said it's a grade B. Actually, it's a grade C because more than 1 is a grade C by definition. So just wanted to attract the attention of the people. I know that those were presented in the publications as a grade A and B, but in reality, they are grade B and C. I just wanted to attract the attention to this. So if you want to allow me to simplify this, this is how I teach it in the grad period program here. To simplify the whole classification system, there are, as you mentioned very nicely in the last 2 slides, and those are great summaries of what the classification system is. But I would suggest to think about the classification in this way. So the first question you want to ask yourself, and many of our students, especially the undergraduate students at the school, do this mistake. They start giving the stage and the grade without asking the first fundamental and basic question: is there a periodontitis case? So the patient might not have periodontitis. Periodontitis, by definition, is, as you mentioned here, is a disease caused by bacterial biofilm in a susceptible host. So if we don't have deep pockets that are bleeding with bleeding and probing, and by deep pockets we mean more than 4 or more. If the pockets are less than 3, that's not necessarily an active periodontitis case, but that's reduced periodontium and could be classified as gingivitis on a reduced periodontium in a previously periodontitis patient or a non-periodontitis patient, depending on the case. Now, to diagnose periodontitis, you have to have deep pockets, and those pockets need to be bleeding, and they have to be on 2 non-adjacent teeth. Ideally, you would have a cal of 5 on 2 non-adjacent teeth. And again, just a reminder that we are looking at 2 non-adjacent teeth, not non-adjacent sites. So for example, distal of tooth number 26 and a mesial of tooth number 27, these are 2 adjacent sites, and they count as one. We need to have the teeth non-adjacent, like not 2.6 and 2.7. It has to be 2.5 and 2.7, or 1.6 and 2.7. Not adjacent sites, but rather adjacent teeth. That's the fundamental question. Now, once periodontitis is established, as a chart or a decision tree, the next step is to establish if the clinical attachment loss is more than 5 on the worst side, or is it less than 5? Because that's the cutoff between two big groups, between stage 3 and 4 or stage 1 and 2. So if it's more than 5, as you said nicely, we start thinking 3 and 4, and we stop thinking about 1 and 2 altogether. If it's less than 5 millimeter of clinical attachment loss, then we limit our thinking about to differentiate between stage 1 and 2, and we don't think about stage 3 and 4, except, as you mentioned here again, except we have modifiers, we have teeth loss to periodontal disease, we have some automatic triggers of some staging. For example, if the patient told you in the history that he lost tooth number 16 to periodontal disease, you immediately don't think about stage 1 and 2 because you already lost one tooth to periodontal disease. Then that patient doesn't classify as stage 1 or 2 because in those stages, as you mentioned, we don't have any tooth loss to periodontal disease. Another automatic trigger for staging is when you have less than 10 pairs of teeth in occlusion, which you wrote here as 20 teeth remaining. If you have less than 10 pairs of teeth in occlusion, that's a stage 4 automatically. For grading, we have the automatic triggers of smoking and diabetes. So if the patient is a smoker, an active smoker or a diabetic patient, that's automatically a grade B unless the smoking habit is more than 10 cigarettes a day. That's a C. And if the diabetes is not very well controlled, more than 7%, and that's a C. So that's a summary of it. You summarized it very nicely in those 2 slides. Practice makes perfect. So though one time I told the patient practice makes perfect, and he's a philosopher, and he said practice makes permanent. What makes perfect is perfect practice. And I agree, perfect practice makes perfect. So the more we diagnose, the more we use the classification system, the better it is. Now, one clinical hint that I would suggest, as a periodontist, when I receive cases from referring dentists and I write back to them with my periodontal report, actually, I purposely put the whole classification system on 4 sheets of paper, like check boxes on a template. And I purposely check the boxes rather than write the classification system. It's not just to make it easier on me, but I use this as an educational opportunity for everybody to remind everybody what does this stage mean. So under stage 3, I list some of the triggers for the staging, and I check the boxes that apply. So I have that template. When the patient comes, my assistant will be just checking the boxes after me as I chart, or I tell her, well, there is a class 2 furcation of tooth number 36. Then she checks furcation 2, and that automatically triggers the diagnosis at the end of the session. So this is another way of doing it. Maybe as a periodontist, I invest a lot of time doing it. Maybe in the real world of clinical practice as a general dentist, general dentists might not have that luxury or that time to do a comprehensive and thorough work with complex periodontal cases. But I would just suggest that initially for maybe a month or 2, because after that, believe me, it becomes ingrained in the brain and it becomes a second nature. You automatically say, by looking at the patient, when I'm asked to look at a patient in the undergraduate clinic or grad perio clinic, the moment they open the radiographs, I look at the chart quickly. I read some of the history about the patient. It takes only a minute or 2 to come out with the diagnosis. The system looks a little bit complex, but in reality, it's much better than what we had before. And once we understand it well, it makes more sense. And as we said all the time about this classification system, I think we can say that this classification system brought the mouth back to the body, and have looked at periodontal patients as patients with general health, with habits, with factors that might affect their general health beyond the effect that happens on their periodontium. Thank you so much. It was a great presentation. I really enjoyed it again. And I just have a question, and excuse me for my naivety, if it's a naive question. Did you do periodontal training before, Dr. Salam?
Yes, I have.
Okay.
Back home, yeah.
Okay, because
Yeah,
that shows Yeah, I can see that, you know, you really understand the classification system very, very well beyond, you know, it's on a specialist level, which I really appreciated. Thank you very much.
Thank you so much, Dr. Hamdan. Thank you for any addition you did. It's really good.
Thank you.
Thank you, Dr. Hamdan. Thank you, Dr. Salam. This was definitely a great presentation. Now, if anybody have any questions, now is the time. As we always do, please write them in the chat for us, please. And we will present them to Dr. Salam and Dr. Hamdan.
Just a reminder to everybody, I'm sure Dr. Salam knows this as we are waiting for questions. But just to confirm that the staging does not go back like with the exception that we mentioned. The grading does though. Like if somebody is smoking 15 cigarettes a day, and after a while they start smoking 5 cigarettes a day, that will bring them from stage C to, from a grade C to a grade B. So the grading could improve, but not the staging. The staging in general, with the exception of the regeneration that we spoke about, does not improve, but the grading does, depending on the why the patient had that grading.
Yes, we can go back in grade or just move from grade B to A, but we can't when stages, with the exception you mentioned earlier, where we do regenerative therapy.
Yeah. Actually, just another thing, the clinical significance or the knowledge translation component of this grading and staging system, the staging will, as Dr. Salam mentioned, will influence your treatment decisions. So I know that with the stage 3 or 4, there is a high probability of using some form of surgical therapy. But for stage 1 and 2, most probably we are limited to non-surgical therapy in general. However, the grading, on the other hand, that's for the staging. The grading will kind of influence your periodontal maintenance protocol. So if a patient has a grade C or a grade B, they will definitely be on a 3-4 months maximum schedule. With the grade A, you might get away with the 6-month periodontal maintenance, which is not a preference. And you know, with as Dr. Salam mentioned, with periodontitis patients, they are periodontitis patients for life. So you want to keep them on a 3-4 months schedule for sure. However, with the reality of the practice where patients are limited by their insurance companies and what the insurance pays for their debridement, I wouldn't mind a grade A patient to be treated every 6 months, but definitely not a grade B or C patient. So that's the relevance of the grading system and how you can use it to influence your decision making for periodontal maintenance.
Well, it looks like no one has any questions. So I expect that everybody can answer all the questions that Dr. Hamdan has prepared for us about all the classifications. Okay.
There are a few questions, Dr. Hassan. I can see some.
Oh, you can see them?
Yeah.
It looks like I don't know
Dana
why.
is asking
Yeah.
a few questions and yeah.
Okay. Do you mind? Because for a funny reason, I don't see them. Maybe Dr. Hamdan, if you can.
Can I read those?
Yeah, please.
Yeah, okay,
Please.
okay. So thank you, Dana, for your question. Hi, Dr. Hamdan. I'm a second-year dental student, and I've had a few instructors provide me with different information. I just wanted to ask, is it absolutely necessary to have bleeding on probing to diagnose someone with periodontitis? Or if someone has several probing depths of 6 millimeters with no bleeding or probing, can we say they have periodontitis? That's a very good question, actually, Dana, and that's a matter of controversy. You are right. Bleeding on probing is the marker for inflammation. However, we know that it has low sensitivity, as you might have heard those terms, and high specificity, meaning that bleeding on probing could not be necessarily a sign of disease. Patients could bleed with a little bit of an aggressive probing or using a sharp probe or applying more force than required. But the absence of bleeding on probing, the continuous absence of bleeding on probing is a reflection of health, according to evidence. In other words, if the patient does not bleed from a certain site while you did continuous cycles of bleeding on probing, that site most probably is clinically healthy. Now, clinical attachment loss is one thing and inflammation is another. If the patient is maintaining meticulous oral hygiene, they are able to access a deep site with different tools, and they see their hygienist every 3 or 4 months, and they don't bleed, then that site is not inflamed technically from a clinical perspective. We are not diagnosing based on a histologic understanding of what the situation is. We diagnose based on a clinical findings. So based on the clinical findings, if you don't have bleeding on probing, you don't consider those sites as disease sites. However, you have to, and here's the trick, you have to wait. The deeper the pocket is, you have to wait a little bit before you can see the bleeding, because sometimes you have deep bleeding and it takes a few seconds to a minute to appear on the surface. So if you apply the proper force, use the proper angulation of the probe, and the bleeding doesn't happen over different cycles of probing, most probably that's not a disease site and it shouldn't be considered for diagnosis. I know other periodontists, and this is what you are saying, that you are confused because multiple people tell you different things. They will tell you, we can't have a 6 millimeter pocket without periodontitis. Well, I can give you different scenarios where you can have 6 millimeter pockets without periodontitis. One of them is drug-induced gingival overgrowth. You could have a 6, a 7, sometimes an 8 millimeter pocket without clinical attachment loss. That's one scenario, pseudo pockets. If you have a thick phenotype and the patient lost bone because of the malpositioning of the tooth, recession does not happen all the time because of the thick biotype, but you still have loss of bone, then you will have a pocket that might not be diseased because of the patient's ability and the hygienist's ability to clean it. So bleeding on probing still is the factor that we look at mostly. I hope that answers your question. Okay, this question, I'll leave it to Dr. Salam, but I'll read it. Thank you, and great presentation. Periodontal loss due to the extraction of adjacent teeth as extraction of third molars. Does that change the staging when we got attachment loss of the tooth next to it? Because I saw some cases they did change it, but a new study. Okay, I think the question is truncated. Dr. Salam, do you want to take this one from Dr. Ibrahim?
Yeah, so usually when we have a bone defect or bone loss due to an extraction site, and let's say the other teeth are all, we don't have any clinical attachment loss, this is not a periodontal, we don't consider it periodontal loss. So this is basically happened due to the tooth loss that maybe due to, like you said, it's the third molar extraction, maybe they did some bone reduction, and then that developed a bone defect. So this is not due to periodontitis case. We don't have an active inflammation happening. It's due to iatrogenic reasons.
Yeah, I agree. There are a few things that are excluded from being considered. In the past, for example, if the patient had vertical root fracture, and he came to your practice with a deep pocket that's 12 millimeter pocket and clinical attachment loss. In the old 1999 classification, the Armitage classification, that would have been localized severe chronic periodontitis. That's not the case. This is not chronic periodontitis caused by biofilm on a susceptible host. It's caused by vertical root fracture. So vertical root fractures, teeth defects distal to tooth number 7 after the extraction of number 8, all local factors leading to attachment loss, and most facial recessions, unless they are multiple, more than 3 millimeters, with some interproximal loss, those don't really count according to the new classification system. So if you have a cemento enamel, if you have an overhang restoration, that doesn't count as periodontitis, causing some attachment loss. If you have a palatogingival groove on a lateral incisor on the maxilla, that and causing clinical attachment loss, that doesn't count. Vertical root fracture does not count. Defects caused by extraction, as Dr. Salam mentioned, doesn't count. So all those don't count. Okay, so Noor Tamim, thank you, Dr. Salam and Dr. Hamdan. Can we summarize again the periodontal maintenance periods according to staging? You mean grading? I'll leave that to Dr. Salam if she wants to take that one as well.
Yeah, so as you mentioned, doctor, so usually the maintenance period is 3 months. We can go 3 to 4 months, especially in grade B and C. Grade A, however, since it's a slow rate of progression, it's ideally it's 3-4 months as well, as it's like we always have periodontal patient is 3 to 4 months, while non-periodontal patient that comes in every 6 months. But for grade A, since it's a slow rate, so we can control it if the patient is coming every 6 months. As you said, doctor, in real life, and like patient in the office does not always comply with every 3 months. So we do accept 6 months for grade A exclusively. Grade B and C, he has to come in more often, 3 to 4 months.
Mm-hmm. Thank you, Dr. Salam. Dr. Shabnam, that was a great presentation. Thank you. I agree, Dr. Salam did a great job. And you keep thanking me. I didn't do much. The great work and the bulk of the work was what Dr. Salam did. Thank you, Dr. Salam. Thank you, Noor. Thank you, everybody. I can see more questions, Dr. Hassan.
No more question. I just wanna have a quick thought based on the maintenance periods, because I've always been thinking about it. Has there been any studies that looked into the patients who have missed their maintenance periods and see the progression of the disease? Like, have they looked into that? Have they tried to correlate up the patients missing their maintenance visits and the degree of the progression of the disease?
Do you want me to answer that, Dr. Salam?
Yes, sir.
Yeah, multiple, Dr. Hassan, multiple studies in the classic periodontal literature. One very famous one that comes to mind is by Hirschfeld and Wizerman. This is a classic study where they followed patients for 22 years in their private dental practice, and they found that those patients with excellent compliance, who are really compliant with their maintenance protocols, managed to maintain their teeth, and they lost less than 1 tooth on average over 22 years, despite that they were periodontitis patients. Patients who were not compliant lost between 6 to 10 teeth and that's a famous study, and they followed 600 teeth. So it's a good sample size, long-term, and that was a finding by Hirschfeld and Wizerman, actually. Wilson did another interesting study. Wilson found that only 16% of patients are compliant with their periodontal maintenance protocols. 33% are non-compliant, and about half are erratic. So sometimes they come, sometimes they don't. And then they complemented their study by some follow up and reminders and sending text messages to patients and asking them to come and that sort of thing. And they found that the compliance rate improved, and then the patients had better outcomes, periodontal outcomes moving forward. I would say most of the studies will quote that tooth loss is limited to less than one tooth over a period of 5 to 22 years if the patient is compliant with periodontal maintenance therapy. Periodontal maintenance therapy does magic to patients if they comply. We know from evidence, but we don't want to tell patients that fact, that if patients come to see the hygienist every 3 months, and the hygienist does a high quality periodontal maintenance appointment to them, they could be maintained regardless of home care. This is surprising a little bit, isn't it? Like if patients don't really bother to brush their teeth well at home for 3 months, if they see the hygienist and the hygienist that does a very good job every single 3 months, they wouldn't have destruction beyond what a patient who's having a good oral hygiene would have. The reason is it takes 3 months for anaerobic bacteria and the red complex bacteria that causes most of the destruction to form complex biofilms and cause the destruction. It takes that bacteria 3 months. The colonies start immediately after you do the debridement. Bacteria starts to form the cuticle, the pellicle, and that sort of thing. Then it becomes a complex biofilm, but it takes 3 months for the complex biofilm to be well established and start to cause destruction again. So if the hygienist goes every 3 months and disrupts the biofilm, the biofilm will start the cycle again, and it will take the biofilm another 3 months to recover. For that reason, we tell the patients, if you come and see the hygienist every 3 months, you should be fine. But we never tell them that you don't need to brush, because if they know this fact, they will not brush very well, which is not good for them. But we have to be mindful between the difference of clinical health and histologic health. Patients wouldn't be healthy on a histologic level. There will be cytokines and toxins leaking into their system if they don't brush well, but clinically they wouldn't have clinical attachment loss. They will have gingivitis after 48 hours. And again, that was a famous study by Lang on his dental students, where he asked them to refrain from brushing their teeth. And he complemented the study by asking them to brush the minimum number of times. And he wanted to find clinical gingivitis, at what extent. If you do really a good job in brushing your teeth, you really don't need to brush every single day. You need to brush once every 48 hours. Of course, again, we don't tell that to patients, because patients wouldn't typically do an excellent job in brushing their teeth. That's why the recommendation is to do 2 minutes 2 times a day. But the clinical, based on evidence, if somebody brushes high quality brushing technique, performs a high quality brushing job with using the additional aids like the interdental floss, they should be fine every 48 hours. Interesting facts that we don't share with patients.
Very, very informative, Dr. Hamdan. I guess the dental students that are attending today, and there's few of them today, should know that they're very grateful to study dentistry in Canada. Otherwise, they would have just been subjected, to clinical trial by Dr. Lang. Would have been like prohibited from brushing teeth. And is he the same one that extracted up the wisdom tooth and placed an implant and then took the implant? Is that the same person?
I think he is, but by the way, I met him in 2015, and I asked him how come you got away with those studies by ethics. How did ethics approve this? Because he practices in Switzerland, in Bern, and Nicholas Lang, and he told me in the old days we didn't have the same strict ethical systems that we have these days. So now I'm not doing those studies in Switzerland. I started doing them in Napoli, in Italy. I told them, okay.
That's a good
Okay.
one. That's a good one. That's a good
Yeah,
one.
I told him, do you do this? He said, now we do it on implants. We put implants, then we take in block sections to look at the bone implant contact. And he said in Switzerland that was not approved. Unfortunately, it was approved in Italy. So he went there and he's doing it right now, actually. He's doing those studies.
That's amazing. That's
You know,
actually is amazing.
one interesting study about Dr. Lang, which dental students might find shocking. First, in today's world, you can't do research on your students because there is a power dynamic here. It's not ethical to do research on students, on people who can't say no to your offer to them in general. There is a power dynamic in a play. But what he did, actually, he placed MOD restorations, amalgam restorations, on pristine teeth on his dental students. And not only that, he left some restorations with overhangs more than 2 millimeters purposely to see what would happen if we leave an overhang restoration without cleaning. So obviously those poor patients or those poor students developed clinical attachment loss around those overhang restorations. So he divided the students into 3 groups. One group without restorations, one had excellent restorative work done, despite that they didn't have cavities. And another group, they had restorations placed without a matrix band, MOD.
Amazing. Absolutely amazing. Very interesting. So I don't know if you see, because Dr. Hamdan, I don't see on my screen any other questions. I want to again thank you and thank Dr. Salam for this wonderful presentation. I want to thank you for your time. Just a quick couple